Usually medical diagnoses offer this really comforting precision. Like if you're in A&E and you break your arm, an X-ray shows a jagged white line and the attending physician just points to the fracture and says, there's the problem.
Right, yeah, it's so totally binary.
Exactly. It's visible. You cast it, the bone knits back together, the cast comes off, and the patient just, they walk out of the clinic entirely restored to their previous life.
Which is the classic traditional biomedical model. I mean, it relies on this very neat linear progression from pathology to intervention and then finally to cure. And to be fair, it works beautifully for a fractured radius.
It does, and this is what we're exploring today, the moment a clinician steps into the world of severe psychiatric illness, that entire linear framework just shatters. We aren't looking at a simple mechanism of injury anymore.
No, not at all. Because psychiatry at its absolute core is the study of how the brain, the mind, and human experience all constantly interact, and critically, how that incredibly delicate compounding process goes wrong.
Right. And because the pathology is so completely interwoven with the patient's identity and their environment, the recovery process demands a totally different paradigm.
Yeah, you cannot simply treat the cellular mechanism and then just, assume the patient's life will organically rebuild itself. It just doesn't happen.
So to really grasp this, we're diving into Chapter 12.13 of Kaplan and Sadok's comprehensive textbook of psychiatry. Our mission for this deep dive is to build your mental models, clarify the mechanisms of psychiatric rehabilitation, and really strengthen your clinical reasoning.
And we are specifically moving from the mechanism of the illness to its manifestation and finally to its clinical meaning.
Spot on. And to set the stage for this, I want you to imagine a metaphor. Imagine a really dedicated psychiatric clinician, like a sort of Medlock Holmes' character.
Medlock Holmes, I like that.
Right. So Holmes has spent years mastering neurochemistry, psychopharmacology, diagnostic criteria. He enters a psychiatric hospital expecting to find his next clinical mystery inside the consulting room. But instead, the patient is waiting for him at the front gate.
Meaning the acute clinical crisis is over.
Exactly. The intervention was a massive success on paper. The antipsychotic medication effectively antagonized the D2 dopamine receptors in the mesolimbic pathway. The patient's auditory hallucinations they've quieted down to a whisper.
The acute paranoid delusions have lost their terrifying intensity.
Right. Blood levels are optimal. So the medical chart dictates that this is a victory.
Because by the strict metrics of acute biological psychiatry, the crisis has been averted. The active disease process is arrested.
But then our Medlock Holmes looks past the medical chart. He looks at the actual human being sitting in front of him, and yes, the hallucinations are gone, but this patient has nowhere secure to sleep tonight.
Yeah.
They haven't held a job in 5 years, they've lost contact with their family, they have no friends, and frankly, they have zero meaningful reason to wake up tomorrow morning.
Which highlights the most profound paradox in our field. The medical treatment successfully reduced the illness, but it completely failed to restore the life.
Yes. So Holmes follows this man beyond the hospital walls and discovers what we might call the city of interrupted lives.
That's an incredibly powerful image. The city of interrupted lives.
And its streets are just lined with empty apartments, locked workplaces, abandoned classrooms. There are train platforms leading nowhere. And each of these represents an ordinary adult role, tenant, student, employee, partner, that severe mental illness can just completely disrupt.
And treating only the positive symptoms of schizophrenia without initiating rigorous psychiatric rehabilitation is, it's essentially an incomplete medical intervention.
It's like putting out a massive raging fire in someone's house, but then just packing up the hoses and leaving the residents to live in the charred, waterlogged remains.
Spot on.
You haven't given them the blueprints or the tools to rebuild. You've just stopped it from actively burning to the ground.
And that analogy cuts right to the neurobiological reality of the illness. The fire, in this case, represents the acute psychotic break, that overwhelming surge of dopamine that fuels the hallucinations and delusions.
And the water is the antipsychotic medication.
Exactly, and we cannot understate this. Without the medication, the fire consumes everything. It is vital. But once the fire is out, you are left with the structural damage. And in schizophrenia, that damage isn't just psychological.
No, it's profoundly neurodevelopmental and cognitive. Let's really dig into that structural damage. Because if you want to understand how to rebuild the house, you have to understand what exactly got burned away.
Right.
We're talking about a disease that doesn't just spontaneously start with the first hallucination in a uni-dorm room, right?
Far from it. The etiology of schizophrenia, as detailed in the textbook, points to a highly heterogeneous compounding cascade of vulnerabilities.
So it's building up over time.
Exactly. It usually begins with genetic predispositions combined with prenatal or perinatal insults. So maybe hypoxia during birth or a severe maternal infection. And then you add postnatal environmental stress to that mix.
So the foundation of the house is actually compromised long before the fire ever starts.
Precisely. Long before the overt dramatic onset of psychosis, which, as you know, typically hits in late adolescence or early adulthood. These patients often display subtle neurodevelopmental abnormalities.
What kind of abnormalities are we talking about?
Well, if you look back at their childhood records, you frequently see mild struggles with attention, working memory, executive functioning, even subtle motor and social deficits. The vulnerability is quite literally woven into the architecture of their developing brain.
And then the disorder fully manifests. The positive symptoms take over. But the reason the charred remains of the house are so incredibly difficult to live in is because of what the medication leaves behind, isn't it? The negative and cognitive symptoms.
This is exactly where the limits of our current pharmacotherapy become glaringly obvious. First generation and even most second generation antipsychotics are targeted primarily at that mesolimbic dopamine pathway.
They block the dopamine receptors to stop the delusions.
Right, but they do very little, if anything at all, to address the hypofrontality.
The decreased activity in the prefrontal cortex.
Exactly. And that hypofrontality is what drives the negative and cognitive symptoms.
So the patient is no longer hearing voices, which is great, but they are still dealing with a profound lack of motivation, blunted affect, anhedonia, just this total inability to experience pleasure.
And, crucially, severe deficits in working memory and executive functioning.
Which means what, functionally?
It means that planning a basic sequence of events, like, say, figuring out how to take the bus to the local supermarket, buy the right ingredients, and cook a meal, becomes an overwhelmingly complex cognitive task.
Wow. Which completely explains why simply handing them a prescription and saying, cheerio, good luck, is a massive failure of care. The medication doesn't teach you how to organize your day when your executive functioning is that compromised.
Not at all.
And furthermore, we're sort of assuming the medication even put the fire out completely. The data from the text shows that's not always true, is it?
It's a really sobering statistic, actually. At least 20% of patients with schizophrenia experience psychotic symptoms that simply do not respond to antipsychotic medications.
20%.
Yes. They have treatment-resistant schizophrenia, and a significant portion of the remaining patients only ever achieve a partial response. So they're walking through society with active, distressing symptoms despite our absolute best pharmacological efforts.
And even for the patients who do achieve total remission of those positive symptoms, no pill can reverse the sociological damage. I mean, a D2 antagonist cannot erase the toxic consequences of societal stigma, can it?
No, it can't. And it cannot magically replace the crucial years of impaired learning.
Right.
Or grant someone the mastery of adult developmental milestones, forming a romantic partnership, starting a career, finishing their education, that they completely missed out on while they were floridly psychotic or institutionalized.
There's a quote in the text. Eugene Bleuler, the Swiss psychiatrist who actually coined the term schizophrenia, he astutely described the usual course of the illness as healing with scarring.
It's a perfect description.
So biological psychiatry handles the healing part, stopping the active disease process. And psychiatric rehabilitation is the incredibly complex science of managing and adapting to the scar tissue.
Historically, though, the medical establishment viewed those two tasks as entirely distinct silos.
Like completely separate jobs.
Exactly. The psychiatrist managed the brain chemistry in the clinic, and maybe a social worker or an occupational therapist managed the life out in the community.
But modern practice demands they be integrated.
It absolutely demands it. Longitudinal studies over the past century indicate that only about 10% to 15% of patients with schizophrenia recover completely and spontaneously.
So the vast majority need help with the scar tissue.
The vast majority require multifaceted, really aggressive interventions that combine symptom management with functional recovery. You cannot treat the scar tissue if the wound is still actively infected.
Right.
And you cannot simply treat the infection and ignore the fact that the patient cannot walk because the scar tissue has contracted their joints.
That brings us perfectly to the actual landscape these patients have to navigate. Going back to our metaphor, at the center of the City of Interrupted Lives stands the Office of Psychiatric Rehabilitation.
And its purpose isn't just to make patients less symptomatic.
No, it's to help people live successfully in the environments they actually choose. So it focuses on three essential elements, or districts, if you will.
Opportunity, support, and skills.
Let's walk into the first district, the quarter of opportunity. Because when a patient walks out of the clinic, they are facing a world of locked doors. Landlords who outright refuse applications. Employers who just assume incompetence.
Services that segregate people into psychiatric spaces rather than actually helping them enter ordinary community life.
Stigma has built literal walls around the city. So rehabilitation has to begin by opening doors. We're talking access to housing, education, competitive employment. Let's start with the most fundamental human need: shelter.
To really understand the modern approach to housing severely mentally ill patients, we have to look back at the historical mechanisms of psychiatric care.
All right, how did we get here?
Well, if you examine the 19th century, the prevailing model was moral treatment. The philosophy then was to remove individuals from chaotic, stressful urban cities and place them in benign, peaceful asylum environments.
They genuinely believed the environment itself was curative, didn't they?
They did. Patients were encouraged to take on normative roles within the asylum: farming, gardening, maintaining the grounds.
A bit idyllic on paper, but segregated.
Exactly. Then, following World War I, and particularly around 1943, the United States saw this massive influx of veterans returning with severe physical disabilities.
Right, requiring massive rehab.
Yes. The government rapidly developed robust physical rehabilitation models, focusing heavily on vocational retraining. And eventually, psychiatric thinkers realized that these functional rehabilitation models could actually be adapted for patients with severe mental illness.
But the real earthquake in psychiatric care, the thing that changed the landscape forever, happened in the 1960s and 70s with deinstitutionalization.
It completely upended everything. The advent of early antipsychotics, combined with shifting legal and social paradigms, led to the dismantling of the massive state hospital systems.
The locus of care shifted dramatically to community mental health centers.
The theory was beautiful. Patients would be supported in their own communities through case management, supported housing, and supported employment.
But the reality was that the funding didn't follow the patients into the community.
It was a catastrophic policy failure in many respects. Patients were discharged into communities that were entirely unprepared and severely under-resourced to handle them.
Which basically birthed the modern crisis of severe mental illness intersecting with chronic homelessness.
Precisely. And this brings us to a really fascinating disciplinary divide in how we view the problem today.
Oh, between the researchers.
Yes. When a mental health researcher looks at a chronically homeless individual sleeping on a pavement, they see a psychiatric failure. They see someone caught in a revolving door, cycling through A&E in the streets due to untreated schizophrenia. They see the broken brain.
But when housing researchers or sociologists look at that exact same individual, they see an economic failure.
Exactly. They argue that homelessness is fundamentally driven by a lack of affordable, subsidized housing and systemic poverty.
So who is actually right?
For the patient with severe schizophrenia, they both are. The clinical reality is that you cannot neatly untangle the biology from the sociology. The patient desperately needs safe housing, they need intensive psychosocial supports, and they need rigorous medical treatment.
So how did the psychiatric establishment historically attempt to house these patients? Because from what I read in the text, the early models were incredibly restrictive.
The traditional approach was deeply paternalistic. It was built on an assumption of profound deficit. It relied heavily on segregation, congregate living so's, think large group homes, halfway houses, boarding facilities.
Segregating them from the rest of society.
Yes. The underlying clinical assumption was that patients with serious mental disorders were simply not competent to live independently in the community.
But what if a patient wanted their own flat? What if they wanted autonomy?
They had to earn it.
Earn it how?
The traditional model operated on a really rigid continuum of readiness. A patient was only offered an independent apartment if they could prove they were compliant and stable.
Meaning what, exactly?
Meaning strict, mandatory participation in mental health treatment, total medication adherence, and absolute abstinence from any substance use. Housing was basically utilized as a reward for good clinical behavior.
But hold on, if we just established that schizophrenia fundamentally impairs executive functioning, working memory, and often features a profound lack of insight into the illness itself, anosognosia, then requiring these patients to navigate a complex multi-step bureaucracy of behavioral compliance just to earn a roof over their heads. I mean, that is biologically absurd.
It is.
You are demanding they demonstrate the exact cognitive skills their brain disease has damaged in order to get shelter.
That is the precise flaw in the readiness model. It creates an impossible barrier. Furthermore, the skills they were expected to learn in these congregate settings rarely actually transferred to the real world.
This is what the text calls the driving simulator problem, right?
Exactly. Teaching someone how to budget their money or cook a meal in a highly supervised, sterile group home doesn't mean they can execute those skills when they are alone in a chaotic apartment building with real-world stressors.
Because the cognitive load of transferring that skill is just too high for someone with hypofrontality.
Spot on. And this realization paved the way for assertive community treatment, or ACT teams.
ACT was a massive leap forward, wasn't it?
It was. Instead of expecting the patient to come to the clinic and prove they were ready, the ACT model takes the clinic to the patient.
So they go into the community.
Yes. It utilizes a multidisciplinary team. So psychiatrists, nurses, social workers, vocational specialists operating 24 hours a day, 7 days a week, entirely in the community.
So if a patient needs to learn how to grocery shop,
The ACT team doesn't use flashcards in the office. They go with the patient to their actual local supermarket and manage the anxiety and the executive planning in real time.
the community itself becomes the classroom. That's
Yeah.
brilliant. But even ACT wasn't the final evolution of housing support. The true paradigm shift, the one that radically altered how we view opportunity for these patients, is a model called Housing First.
Housing First completely inverted that traditional paternalistic pyramid. The core, uncompromising principle of Housing First is offering affordable, independent housing without preconditions.
Meaning just handing them the keys, no strings attached.
None. There is no requirement for the individual to participate in psychiatric treatment. There's no requirement to take antipsychotic medication. There is no requirement to maintain sobriety. In this model, housing is viewed as a fundamental human right. It is the necessary foundation from which a person can pursue recovery, not a reward they must earn by proving their clinical obedience.
Okay, I have to challenge this because to a lot of people, this sounds like a massive liability. If you take a chronically homeless patient with severe treatment-resistant paranoia and a co-occurring substance use disorder, and you just hand them the keys to a private apartment with zero requirement that they see a doctor, aren't you just enabling them to deteriorate in private?
It's a very common concern.
Aren't you basically funding their isolation? Let's look at the case of James from the text to break this down because it perfectly illustrates this tension.
James is the perfect clinical manifestation of this debate. He is a 50-year-old man who has been continuously homeless for 20 years.
2 decades on the street.
Yes. He has severe schizophrenia characterized by profound paranoia and auditory delusions. He walks the streets wearing an eye patch, preaching his religious delusions at high volume, which, as you can imagine, constantly draws the attention of law enforcement.
And his clinical history is basically a nightmare of treatment resistance. He doesn't respond well to medication, and he self-medicates heavily with marijuana.
Which only exacerbates his psychosis and gets him entangled with local drug dealers.
Yeah.
He has failed out of every single traditional, rules-based group home because his behavior is simply too chaotic.
He is the ultimate unhousable patient under the old readiness model.
Exactly. So following a long stint in a forensic hospital, a Housing First team engages James, and they do the unthinkable in the eyes of traditional psychiatry. They offer him his own apartment, totally unconditionally.
Okay, so what actually happens when he moves in? Because surely the psychosis doesn't just evaporate because he signed a lease.
It doesn't evaporate at all. But the clinical reasoning of the Housing First team is vital here. They didn't just abandon him in the apartment, they provided intense 247 voluntary support.
Right, voluntary being the key word.
They used radically respectful listening. When James ranted about his delusions, they didn't argue with him or threaten him with eviction for being non-compliant. They just listened and offered practical help.
And because the support was completely decoupled from coercion, it changed the psychological dynamic.
It fundamentally shifted his locus of control. For the first time in 2 decades, James had a safe sanctuary that he actually loved. He had something of value to lose.
So when the local drug dealers realized he had a private flat and tried to take it over as a base of operations,
James was terrified. But instead of running back to the streets like he used to, he asked the Housing First team for help. They stepped in and helped him set firm boundaries with the dealers.
But the most fascinating mechanism here is how James rationalized changing his own destructive behaviors. He didn't suddenly develop profound psychiatric insight into his schizophrenia, did he?
No, and clinicians really must understand this. You do not need full clinical insight to achieve functional recovery. James developed his own delusional rationales for behavioral change.
What does that look like?
Well, within his own complex belief system, he decided to give up marijuana. He voluntarily restricted his public preaching so he wouldn't get arrested. He even approached the psychiatrist and agreed to take a low dose of antipsychotic medication.
Why? If it wasn't a rule for his tenancy, why did he comply?
Because he realized that his chaotic behaviors threatened his tenancy. He desperately wanted to keep his beloved apartment. Autonomy bred a level of compliance that 2 decades of institutional coercion could never, ever achieve.
That is a staggering psychological mechanism. It's the difference between forcing someone to behave and giving them an environment worth behaving for.
Beautifully put.
But is James an outlier? I mean, does the macroeconomic data actually support this radically permissive approach on a large scale?
It really does. We have massive, pragmatic, randomized controlled trials across the United States and Canada analyzing the housing first model. The empirical evidence is unequivocal.
What do the numbers look like?
Housing first results in remarkably high long-term retention rates in independent housing, usually upwards of 80% to 85% remaining stably housed after several years. It pulls people off the streets permanently.
And what about the financial cost? Because apartments aren't cheap.
It actually saves the healthcare and legal systems an astronomical amount of money because it drastically reduces the utilization of acute psychiatric hospitals, A&E departments, and jails.
But let's be intellectually honest about the clinical data here. Does getting an apartment cure the underlying neurobiology?
No. And this is a vital caveat for anyone studying this model. The longitudinal data does not show that housing first automatically improves the clinical symptoms of psychosis, nor does it reliably cure co-occurring substance use disorders.
James still has schizophrenia. He still has delusions.
Exactly. So housing is the necessary foundation, but it is not the complete architecture of a recovered life. It provides the safe room to sleep in, but a person cannot spend the rest of their life just sitting alone in a quiet room.
They need an identity. They need a purpose, which requires us to cross into the second district, the bridge of support, specifically the vocational crisis. Because once the door is unlocked, the patient needs a reason to leave the apartment in the morning.
We need to talk about employment. And the statistics here are genuinely bleak. They are an indictment of our systemic failures.
How bad is it?
Across the United States, less than 15% of patients with schizophrenia are engaged in competitive employment.
Less than 15%. We are writing off the productive capacity of an entire population.
And it is not by their choice. Survey after survey reveals that between 50% and 75% of individuals with severe mental illness explicitly state that obtaining a competitive, normal job is one of their absolute primary life goals.
So there is massive internal motivation, yet a 15% success rate. The clinical meaning of this involuntary unemployment is devastating. It drives them into deep, chronic poverty, and psychologically, it completely erodes their self-efficacy.
They internalize the belief that they are fundamentally broken and incapable of contributing to society.
Historically, the psychiatric establishment recognized this desire to work, didn't they? But the mechanisms they designed to facilitate it failed completely.
Yes, for decades, the field relied heavily on what we call train-in-place models.
The logic seems sound on the surface. You train a patient how to work, and then you place them in a job. Why did it fail so spectacularly?
It failed because it operated on the exact same flawed paternalistic readiness assumption as the old housing models. These programs utilized endless pre-employment cognitive assessments, day treatment centers, and most notably, sheltered workshops.
Describe a sheltered workshop for us, because the reality of these places highlights exactly why they don't work.
A sheltered workshop is a segregated environment where patients with mental illness work exclusively alongside other patients. They are typically given highly repetitive, menial, sub-minimum wage tasks, sorting buttons, folding flyers, assembling simple parts.
And the theory was what?
The theory was that this low-stress environment would gradually build their cognitive stamina and work habits until they were ready to graduate to a real job in the community.
But the neurology of schizophrenia doesn't work that way. As we discussed with hyperfrontality, these patients struggle massively with generalizing skills across different contexts.
Right.
Sorting buttons in a quiet, highly supervised clinic does not neurologically prepare someone for the chaotic, high-stress, rapidly shifting environment of a fast food kitchen or a retail stockroom.
The context-dependent learning completely failed to transfer. Furthermore, the psychological impact was disastrous. Patients stalled out. They spent years in these preparatory phases, feeling infantilized, and they just became incredibly discouraged.
It's the driving simulator all over again. You can't learn to merge onto a motorway by playing a video game in a clinic.
Exactly. The data definitively showed that these stepwise train-in-place approaches did absolutely nothing to improve the rates of actual competitive employment in the community.
So in the 1990s, the paradigm shifted.
Yes. Driven largely by the consumer recovery movement, we saw the advent of place and train models. And the absolute gold standard of this is individual placement and support, or IPS.
Let's examine the mechanisms of IPS because it turns traditional vocational rehabilitation completely upside down. It's based on 8 core principles in the text, right?
Yes. And the defining radical principle of IPS is zero exclusion.
Meaning anyone can work.
Anyone who expresses a desire to work gets immediate assistance. There are no assessments to prove readiness. We do not exclude patients because their symptoms are severe, because they have severe cognitive impairments, or even if they are currently actively using illicit substances.
But surely a clinician can look at a floridly psychotic patient and accurately predict that they will fail a job interview.
The research definitively proves otherwise. Decades of data show that psychiatric professionals, case managers, and vocational rehabilitation counselors are statistically terrible at predicting which patients will actually succeed in competitive employment.
We cannot reliably gatekeep.
Therefore, we must not gatekeep.
What about the placement itself? Are we still looking at sheltered work?
Absolutely not. IPS mandates a focus purely on competitive employment. This means real jobs in the real community, paying at or above the prevailing minimum wage. The patient is an employee of the business, not a client of a rehab center.
And the mechanism of getting the job is vastly different. IPS requires a rapid job search.
This is critical psychological mechanism. There are no endless months of resume building or mock interviews in a clinic. The employment specialist helps the patient actively apply for real jobs within 30 days of entering the program.
Why so fast?
Because this rapid pacing bypasses the anticipatory anxiety that often paralyzes patients, and it capitalizes on their immediate motivation.
And the employment specialist isn't just handing them the local classifieds, right? They're actively involved.
Yes, they engage in targeted job development. The specialist goes out into the community, builds relationships with local employers, and finds jobs that match the specific preferences and strengths of the patient.
Honoring client preference.
Exactly. If the patient loves being outdoors and hates crowds, the specialist advocates for a landscaping position, not a busy retail checkout job. Honoring client preference is a core principle because the data shows job tenure is significantly longer when the patient actually likes the work they are doing.
But the support doesn't stop once they get the job. That's the train part of place and train.
Exactly. The ongoing support is individualized and continuous. The employment specialist might help the patient manage workplace anxiety, figure out the most efficient bus route, or even mediate a conflict with a manager.
And critically, this specialist is fully integrated into the mental health treatment team.
They sit in on clinical meetings with the psychiatrist and the case manager so that the medical treatment and the vocational goals are perfectly aligned.
There is one massive practical barrier we have to address, though. The welfare cliff.
Ah, yes. It is the single biggest fear for many patients. They are terrified that if they earn a single competitive paycheck, the government will instantly strip them of their disability benefits, their housing vouchers, and their health insurance.
So IPS has to address that.
It mandates highly individualized benefits counseling to help patients navigate this complex economic reality and understand exactly how work will affect their specific financial safety net.
Let's ground all of these mechanisms in a clinical manifestation from the chapter, the case of Antonio.
Antonio's story perfectly illustrates the failure of the old model and the triumph of IPS. He is a 45-year-old man with schizophrenia who has been stuck in a rehabilitative day treatment program for over 10 years.
A decade in a clinic.
Yes, and he has entirely internalized the sick role. He firmly believes he cannot work because of his diagnosis. Furthermore, he had a hard practical constraint. He is a devoted father and he needs to be home by 3 p.m. every day when his children finish school.
Under the old train-in-place model, Antonio is permanently excluded. He lacks self-efficacy, he is highly symptomatic, and he has restrictive time constraints. He would never pass a readiness assessment.
Never. But his clinic transitions to the IPS model. An employment specialist sits down with Antonio. They don't administer a cognitive test. They simply ask him what he enjoys doing.
What does he say?
Antonio says he likes driving, and despite his symptoms, he is a generally friendly, sociable guy.
So they leverage his preferences and bypass the deficits.
Exactly. Through rapid job search and employer networking, the specialist finds Antonio a part-time job delivering Meals on Wheels. And critically, they negotiate the hours to be strictly from 10:00 a.m. to 2:00 p.m.
Perfectly aligning with his need to be a father first. What is the clinical outcome of this rapid placement?
The transformation is profound. Antonio's attendance is nearly perfect. The psychological mechanism driving this is that he finally feels genuinely needed by the vulnerable elderly people he delivers food to. It restores his sense of purpose.
He achieves social integration with his coworkers, managing his symptoms in a real-world environment.
But the most striking detail in the text is how it affected his identity. He reported to his clinical team how incredibly proud he was that his children finally saw him leaving the house to go to work, just like the fathers of their friends.
Wow.
He transitioned from a passive patient to an active provider. He built a life larger than his illness.
It's a beautiful outcome, but I have to push back with the most common clinical fear I hear. When I talk to psychiatrists, they are often terrified of IPS. They worry that taking a fragile, cognitively impaired patient and throwing them into the crucible of a high-stress competitive job is going to trigger a massive psychotic relapse.
It is an incredibly pervasive fear.
Does the stress of work cause clinical decompensation?
The empirical data completely dismantles that fear. We have over 28 rigorous randomized controlled trials evaluating IPS across varying economic landscapes. The evidence explicitly demonstrates that engaging in competitive employment does not produce clinical instability.
It doesn't make them sicker.
It does not lead to higher rates of psychotic relapse or increased psychiatric hospitalizations. The opposite, in fact. Work acts as a clinical stabilizer. It provides routine, social connection, and improved self-esteem.
And how effective is it compared to the old way?
The efficacy is undeniable. Clients enrolled in IPS programs achieve competitive employment rates that are consistently 2 to 3 times greater than those in traditional vocational or day treatment programs. The place and train mechanism is one of the most robustly proven interventions in all of psychiatric rehabilitation.
So we have explored opportunity through housing first, and we have built the bridge of support through IPS employment. Now, we enter the final domain of our rehabilitation landscape, the workshop of skills.
Which brings us to the digital frontier.
How do we actually teach these patients to manage their daily lives, their symptoms, and their social interactions in real time? This is undoubtedly the most rapidly evolving, disruptive area of psychiatric rehabilitation today.
It is. But before we can even discuss the clinical applications of digital technology, we have to confront and dismantle a massive paternalistic bias within the medical community.
The technology myth. There is a pervasive assumption among clinicians that individuals with severe chronic mental illness like schizophrenia are somehow fundamentally incapable of utilizing modern technology.
It's a bias rooted completely in the old deficit model, and the demographic data entirely shreds it. Recent extensive surveys indicate that between 80% to 94% of people diagnosed with schizophrenia access the internet regularly.
So they are online.
Furthermore, 86% to 97% own and actively utilize mobile technologies, including smartphones.
They are not digitally isolated. They are just as connected as the general population.
In many ways, they are leveraging technology faster than the clinical establishment. Patients with severe psychosis are actively using platforms like YouTube to post incredibly vulnerable video testimonials about their experiences with hallucinations and paranoia.
Really?
Yes. They are completely bypassing the traditional stigmatized clinical settings to build their own virtual communities of peer support and shared coping strategies.
So the patients are already online. How is the field of psychiatric rehabilitation catching up and leveraging that connectivity?
We are seeing the deployment of highly sophisticated web-based interventions. A prime example highlighted in the literature is a program called Coping with Voices.
What is that?
This is a self-directed interactive web platform specifically engineered to address distressing auditory hallucinations.
How does a website treat a hallucination? It can't prescribe meds.
No, it doesn't stop the voice. It changes the patient's relationship to the voice. It utilizes a 10-lesson curriculum incorporating videos and interactive exercises to teach cognitive behavioral techniques.
So it's CBT online.
Exactly. It teaches the patient how to reality test the hallucination, how to lower their emotional reactivity, and how to assert control over their attention.
It's scaling cognitive behavioral therapy for psychosis without needing a highly specialized therapist in the room. What about family dynamics? Because schizophrenia isolates families just as much as patients.
For that, we have platforms like SR Schizophrenia online access to resources. SR is brilliant because it is a multi-family intervention.
How does it work?
It connects the patient, their designated support persons, and trained clinicians in a secure online forum. If a family is in crisis at 2 a.m. or has a complex question about a medication side effect, they post it on the forum. They get a response from a clinician within 24 to 48 hours.
The mechanism there is rapid cycle support.
Exactly. And the clinical outcomes are significant. Trials show that participation in SR reduces positive symptoms in the patients and massively increases the family's functional knowledge of how to manage the illness, reducing overall household stress.
And for the younger demographic, the patients who have just suffered their first psychotic break.
There is a platform called Horizons. The period immediately following a first episode psychosis is incredibly delicate. The risk for depression, social withdrawal, and suicide is remarkably high.
So Horizons targets that window.
Yes, it combines evidence-based psychosocial interventions with a highly moderated, closed, peer-to-peer social network. It allows these young adults to connect with others who have just experienced the same terrifying break from reality. The data shows it significantly reduces depression and social anxiety, helping them reintegrate into their peer groups.
But web platforms still require a computer and a deliberate login. The real revolution seems to be mobile health, or mHealth, carrying the intervention in your pocket, accessible at the exact moment of a psychiatric crisis. Let's talk about the Focus app.
Focus represents a landmark development in our field. It is the very first smartphone intervention designed comprehensively from the ground up, specifically for individuals living with schizophrenia.
Break down the mechanism for me, because if I download a meditation app, it just passively sits on my phone waiting for me to open it. That requires executive functioning, which we know is impaired in schizophrenia. How does Focus overcome that?
It overcomes it through a mechanism called ecological momentary assessment, or EM. Focus is not passive. It is highly proactive.
Proactive how?
The application prompts the user multiple times throughout the day, right there in their natural ecological environment, asking brief, targeted questions via the touchscreen.
What is it asking?
It assesses their current symptom severity, their mood, their sleep quality, their social functioning, and their medication adherence.
Why is that better than a psychiatrist just asking them, how have you been feeling this week, during a monthly clinic visit?
Because retrospective recall in schizophrenia is notoriously unreliable due to the cognitive deficits. The patient might only remember the worst day of the month, or they might gloss over a severe paranoid episode entirely.
EMA captures the data in real time.
But Focus doesn't just collect data, it reacts to it. It's a closed-loop intervention.
Give me an example of the closed loop.
Based on the patient's immediate input, the app launches tailored, on-the-spot interventions. If the patient taps the screen to report surging anxiety while on a crowded train, the app instantly launches a guided relaxation and deep breathing module.
Wow.
If they report intense paranoia, it guides them through a step-by-step cognitive restructuring exercise to challenge those specific paranoid thoughts right then and there.
And what happens to all that real-time data?
It is securely transmitted to a remote server, creating a highly detailed longitudinal dashboard for the clinical team. The psychiatrist can log in and see exactly how the patient's mood fluctuated hour by hour over the past month, allowing for vastly more precise medication adjustments and therapy targeting.
Let's see this in action. Let's look at the clinical manifestation through the case of Lakeisha from the text.
Lakeisha's case is incredible. She is a 38-year-old woman suffering from severe persecutory ideation. Her delusions centered entirely around public transportation. She was absolutely terrified to get on a bus because she was firmly convinced that the local transit drivers were actively plotting to kidnap and harm her.
The functional consequence of that specific delusion is total isolation. If she can't take the bus, she can't get to her psychiatric appointments, she can't go to the supermarket, and she can't visit her mother, whom she loves dearly. The delusion has basically shrunk her world to the size of her living room.
Exactly. So her clinical team enrolls her in a trial for the Focus app. Initially, Lakeisha is highly hesitant. She expresses the classic fear that she is simply not tech-savvy enough to use a smartphone intervention.
Which confirms the clinician bias we talked about earlier, but how long did it actually take her to learn it?
After just a single 45-minute training session with a support specialist, she was completely comfortable navigating the touchscreen interface.
So she has the app. Does a piece of software actually give her the courage to face her kidnappers and get on the bus?
It does, through the mechanism of immediate, accessible coping skills. Lakeisha forced herself onto the bus, and when the overwhelming terror hit, instead of fleeing, she pulled out her phone. She used the app's guided breathing techniques to physically downregulate her autonomic nervous system.
She managed the physiological panic in real time.
Yes, and after utilizing the app for 8 weeks, the clinical outcome was profound. She was leaving her house daily. She was riding the bus to visit her mother.
But here is the critical question for defining psychiatric rehabilitation. Did the PSYCH app cure her persecutory delusions?
No. And this is the absolute essence of what we are discussing today. She still experienced the auditory hallucinations, the voices were still there, but the distress and the functional impairment caused by those symptoms were drastically reduced.
So she learned to cope with them.
She learned to use the app's cognitive restructuring techniques to independently challenge her dysfunctional beliefs. She learned to be her own therapist.
That's amazing.
When she felt the panic rising on the bus, she would use the app's prompts to ask herself, what is the actual objective evidence that I am in danger right now? Have I ever been kidnapped on this bus before? She reclaimed her functioning and her independence despite the ongoing presence of the psychiatric symptom. That is the definition of functional recovery.
That is incredible. The text mentions that we aren't just limited to smartphones. For patients who might not be able to afford a data plan or who find a full app too complex, there are simpler digital modalities.
Yes, simple SMS text messaging is proving to be incredibly powerful. Programs like MATS, the Medication and Text Support System, utilize automated algorithms to send simple daily text checking on medication adherence and social functioning.
It's extremely low barrier engagement.
Extremely low barrier. And when programs utilize a human mobile interventionist to text patients daily, they see an astounding 87% response rate.
87%. Why is it so high?
Many patients with schizophrenia suffer from severe social anxiety. Sitting in a room with a psychiatrist can be overwhelmingly intense. But a quick text message feels safe, low pressure, and highly connected.
What about the truly cutting-edge tech? The text discusses virtual reality, which sounds almost like science fiction for a psychiatric clinic.
It sounds futuristic, but the clinical applications are happening right now. We are utilizing highly immersive 3D virtual reality environments to conduct rigorous exposure therapy.
How does that work for psychosis?
Well, if a patient has severe paranoia about crowded public spaces, a therapist can place them in a fully simulated virtual grocery store. The therapist can precisely control the number of virtual avatars in the store, the noise level, the proximity of the avatars.
So it's completely controlled exposure.
Exactly. They can help the patient identify their exact contextual triggers for paranoia in a completely safe, controlled digital space and practice cognitive coping skills before ever stepping foot in a real supermarket.
You could use that for employment training, too.
Absolutely. We are using VR to simulate job interviews. A patient can practice interacting with a virtual hiring manager, making mistakes, managing their anxiety, and refining their social skills without burning a real-world employment bridge.
Now, we cannot discuss the digital frontier without acknowledging the massive, tragic catalyst that accelerated all of this innovation, the COVID-19 pandemic.
The pandemic was a devastating global crisis, but in the realm of psychiatric rehabilitation, it acted as a massive, unavoidable forcing function. Overnight, traditional in-person clinical services and day programs were completely shut down.
The physical infrastructure of care basically vanished.
And health systems were forced, out of sheer survival, to rapidly adopt and scale telehealth platforms, digital clinical messaging, and mHealth apps. It instantly shattered the bureaucratic and regulatory barriers that had stifled digital mental health innovation for over a decade.
It proved that the medical bureaucracy could adapt rapidly when it was given absolutely no other choice.
Exactly. And while in-person care is returning, the landscape of psychiatric rehabilitation is forever altered. The digital tools, the apps, the telehealth infrastructure, they are permanently integrated into the modern standard of care.
So, as we look back over this massive landscape we've covered, the neurobiology, the housing policies, the vocational models, the digital apps, what is the grand synthesis here? If a clinician listening to this takes one core philosophy away from this deep dive, what is it?
The fundamental essence of psychiatric rehabilitation is this. Recovery is not achieved when a patient's symptoms merely become quieter. Recovery begins when that person regains a safe home, a meaningful role in society, a supportive community, and the internal confidence to build a life that is larger than their illness.
You cannot just extinguish the fire, you must rebuild the house.
You must. And you do that by rigorously applying the triad we've explored: opportunity, tearing down the barriers to housing first, and competitive employment; support, providing the vital bridge through IPS and assertive community treatment teams; and skills, leveraging mobile technology, EMA, and community-based learning to teach the patient how to navigate their actual world, not a clinical simulation.
It is a profoundly holistic, deeply humanistic model of care. But before we move into our learning reinforcement, I want to pose a provocative thought experiment based on where this digital frontier is heading.
Oh, I'm intrigued.
We just discussed virtual reality and digital peer networks. As this technology becomes exponentially more immersive, could the community that we are trying to integrate our patients into eventually become predominantly or even entirely virtual?
That is a staggering philosophical and clinical question.
Think about the implications. If a patient with severe treatment-resistant schizophrenia, someone who is utterly terrified of physical social interaction, finds absolute social fulfillment, robust peer support, and perhaps even digital employment entirely through an avatar inside a highly advanced virtual reality community, have they achieved functional recovery?
If they are housed, safe, and finding meaning, one could certainly argue yes.
But it completely challenges our fundamental psychiatric definition of a normative adult role. Is recovery strictly bound by physical integration into geographical society? Or is a thriving digital existence a valid medical outcome for a severely impaired brain?
It forces us to ask what normal actually means in the 21st century. It is an ethical and clinical frontier that the next generation of psychiatrists will absolutely have to grapple with.
Something for you, the listener, to mull over on your commute or between clinical rotations. Okay, let's transition to our learning reinforcement. We want to test the clinical reasoning and the mechanisms we've just unpacked. We'll run through 5 single best answer questions, the kind you might encounter on boards or during rounds. I'll read the clinical scenario and the options. We'll pause for a moment so you can lock in your reasoning, and then we'll break down the exact mechanism behind the correct answer.
Ready when you are.
Question 1, focusing on foundational neurobiological concepts. Let's test our clinical reasoning on this. If a resident asks you about the limitations of pharmacotherapy, antipsychotic medications are most effective in reducing which of the following manifestations of schizophrenia, thereby necessitating psychosocial rehabilitation for the remaining deficits?
Severe cognitive deficits, particularly working memory.
Impaired learning and context generalization.
Positive symptoms of psychosis, such as hallucinations.
Negative symptoms, such as severe anhedonia.
The correct answer is C. Antipsychotics, particularly through D2 receptor antagonism in the mesolimbic pathway, are highly effective at targeting positive symptoms like hallucinations and acute delusions. However, they have very limited and sometimes detrimental impacts on the hypofrontality that drives negative symptoms, cognitive impairment, and psychosocial functioning. This exact neurobiological gap is why functional rehabilitation is a mandatory pillar of care.
Perfect. Question 2, focusing on clinical reasoning and social policy. When evaluating a chronically homeless patient with schizophrenia, according to the modern Housing First model, which of the following is considered a strict prerequisite for the individual to obtain independent housing?
Demonstrated stable adherence to prescribed antipsychotic medication.
Verified abstinence from all illicit substance use.
Mandatory documented participation in an assertive community treatment program.
None of the above.
The answer is D, none of the above. The revolutionary core principle of Housing First is offering affordable, permanent housing without any clinical preconditions. Housing is fundamentally viewed as a human right and the necessary stable foundation from which an individual can begin to pursue psychiatric recovery, not a prize they must earn by proving behavioral compliance to a medical team.
Hand them the keys, then provide the support. Question 3, focusing on the mechanism of vocational support. Which of the following represents a core, evidence-based principle of the individual placement and support, or IPS, model of supported employment?
Requiring extensive prevocational skills training and readiness assessments prior to job placement.
Enforcing a zero exclusion criteria for any client expressing a desire to work.
Utilizing placements exclusively within sheltered, mentally health-focused clinical workshops.
Strictly withholding employment assistance until all psychotic symptoms are fully in remission.
The correct answer is B. Zero exclusion dictates that anyone who wants to work is eligible for immediate assistance, regardless of the severity of their current symptoms, their cognitive impairments, or their substance use history. The mechanism driving this principle is the data proving that psychiatric professionals simply cannot reliably predict vocational success, so gatekeeping based on clinical presentation actively harms patient outcomes.
Question 4, focusing on the integration of technology, the FOCIO smartphone intervention for schizophrenia achieves its primary clinical impact through which specific psychological mechanism.
Connecting patients to 247 live, on-demand video calls with a prescribing psychiatrist.
Utilizing ecological momentary assessment to proactively prompt users and launch tailored interactive cognitive coping skills.
Providing a highly immersive virtual reality exposure environment for persecutory delusions.
Strictly monitoring the patient's GPS location to ensure compliance with mandatory clinic appointments.
The answer is B. The Focus app utilizes ecological momentary assessment. It proactively prompts users throughout the day regarding their symptoms and mood in their natural, real-world environment. Based on their immediate real-time responses, it bypasses the need for retrospective recall and instantly launches on-the-spot interventions like cognitive restructuring or guided relaxation.
And finally, question 5, focusing on clinical meaning and outcomes. When assessing the long-term impact of the individual placement and support employment model, massive randomized controlled trials consistently demonstrate that.
Competitive employment in the community leads to significantly higher rates of psychotic relapse due to workplace stress.
The IPS model is only statistically effective for patients with high premorbid cognitive functioning.
IPS clients achieve competitive employment rates that are 2 to 3 times greater than those in traditional vocational programs.
Patients typically stay in their first job for less than a month due to overwhelming psychiatric symptoms.
The correct answer is C. Across more than 28 rigorous pragmatic trials, IPS consistently achieves employment rates 2 to 3 times higher than control conditions. Furthermore, it achieves this without causing clinical instability or higher relapse rates. Work is a stabilizer, not a trigger. And patients typically maintain their initial jobs for 5 to 6 months, which remarkably mirrors the job tenure rates of the general population in similar roles.
Brilliant breakdown. For those of you wanting to dive even deeper into the data, the neurobiology, and the specific case studies we discussed today, I highly direct you to read Chapter 12.33 in Kaplan and Sadok's comprehensive textbook of psychiatry. It is an absolute masterclass in integrating the biological with the social. We will leave it there for today. Remember, the medical chart may dictate that the patient is biologically stable, but the real clinical mystery and the real profound work of psychiatry is helping them step out of the clinic and rebuild a meaningful life in the world beyond those walls. Keep looking at the whole picture.